Hey guys, I'm Dr. Scott Cleos.
And I'm Dr. Andrea Cleos. And today we're going to be talking about Scott's Achilles, which marks a 1-year anniversary since he ruptured it.
Accordingly, we're going to discuss with you guys some of the anatomy of the Achilles tendon and my own recent experience with Achilles rupture while playing pickleball. Over the next few minutes, we're going to review relevant anatomy, the classification system for Achilles injury, and the respective surgical and non-surgical options to treat various injuries. We'll finish with a brief discussion of the genetic factors that may make you more prone to an Achilles rupture. Warning: if you have a weak constitution and cringe at the sight of open wounds, this video does contain an intraoperative image of my own tendon repair from 11 minutes and 2 seconds to 11 minutes and 12 seconds, so be prepared. In the back of the lower leg, a set of powerful muscles plantar flex the foot and play a critical role in our ability to walk, jump, and run. These muscles attach to the calcaneal or Achilles tendon, so named after the Greek demigod and fabled warrior Achilles. According to Greek mythology, the river Styx formed the boundary between earth and the underworld, and its waters offered powers of invulnerability. To prevent his untimely death, Achilles' mother held the infant by his heel and dipped him into the protective waters. Because the heel did not actually touch the waters, it remained vulnerable throughout his life, succumbing to its eventual injury. There are two main muscles that act on the Achilles tendon and calcaneus of the foot. On the surface, there is the superficial gastrocnemius with its medial and lateral heads. The soleus is a broad, flattened muscle that originates from the back of the upper tibia just underneath the gastrocnemius. A third muscle, the plantaris, is considered a minor accessory flexor of the foot, with its tendon occasionally blending with the fibers of the Achilles distally. This muscle is actually absent in 7 to 20% of the population and therefore is considered vestigial or rudimentary by some authors and experts. As such, its minor contribution to plantar flexion and Achilles injury will be ignored for the remainder of this discussion. As we stated earlier, the Achilles inserts on the large posterior bone of the foot called the calcaneus and is capable of supporting more than the entire weight of the body while plantar flexing the foot. As you can see, this motion is critical to facilitate the basic functions of walking, running, and jumping. The gastrocnemius actually originates above the knee joint, just superior to the femoral condyles. As such, the gastroc is not only a flexor of the foot, but also contributes to knee flexion as well. The deeper soleus originates from the posterior aspect of the proximal tibia below the joint line and therefore is purely a plantar flexor of the foot. The Achilles is the largest and one of the longest tendons in our bodies, averaging approximately 15 centimeters in length and ranging from 11 to 26 centimeters. As with other tendons and ligaments in the body, the blood supply arises from the periphery and therefore the central portion of the tendon is relatively avascular, relying on limited diffusion from the periphery for oxygen and nutrients. As such, when the tendon is strained, it usually fails in this relatively hypovascular critical zone about 2 to 6 centimeters above the calcaneal insertion. This also explains why convalescence from an Achilles rupture is usually prolonged, taking 6 to 12 months for full recovery. The generally accepted classification system for Achilles tear and rupture is called the Kawada classification, originally proposed by Dr. G.T. Kawada in 1990. Dr. Kawada divided Achilles injuries into 4 types, basically to stratify post-injury operative or non-operative management. Type 1 is a partial tear of less than or equal to 50%. Type 1 injuries are managed non-operatively. Type 2 is a complete or near-complete rupture of greater than 50% thickness with a 3 cm or less separation between the proximal and distal tendinous components. This injury is repaired with a primary end-to-end anastomosis. A set of 2 or 4 locking sutures are placed through the tendon ends, 1 or 2 on each side, and the sutures are then tied together to oppose the tendon edges. Type 3 is a complete rupture with a defect gap of 3 to 6 centimeters, and Type 4 is a complete rupture with a defect gap of greater than 6 centimeters. Type 4 is also referred to as a delayed or neglected rupture. Because of the relatively large gap between the ruptured ends of the tendon and the possibility of devitalized or dead tissue in the region of rupture on the delayed or neglected injuries, the orthopedists have come up with some creative ways to repair Type 3 and Type 4 injuries, which we will now demonstrate. Muscles and tendons are contained by a tough fibrous capsule called an aponeurosis. In the gastroc recession or Strayer procedure, the ensheathing aponeurosis is lacerated just above the musculotendinous junction, allowing the muscle to relax and stretch, permitting the surgeon to pull the tendon inferiorly for repair. A tendon graft can fill the gap in a neglected rupture and comes in various forms, including autografts, allografts, and synthetic grafts. Synthetic graft is a woven polyester fiber scaffolding that can be used to fill the gap in the damaged Achilles, providing mechanical continuity and limited ingrowth of native tendinous tissues along the course of the synthetic bridge. Allografts are donor grafts from another individual, and autografts are tendinous material harvested from a donor site of the patient themselves and can include flaps and tendon transfers from adjacent structures in the ankle. A VY advancement was first described for a neglected Achilles tendon repair in 1975. The procedure involves an inverted V incision of the proximal Achilles that is then repaired in a Y configuration. The two tendon ends are then sutured together to effectively lengthen the Achilles, allowing end-to-end repair of the more distal injured segment of the tendon. The Bosworth turndown was first described by Dr. D.M. Bosworth in 1956 and involves freeing a central strip of the Achilles tendon above the area of injury. The flap is then passed through the proximal portion of the tendon, brought down and passed through the distal portion of the tendon, and then brought back up and passed a second time through the proximal tendon. The strip is then sewn to itself to mechanically secure the injured Achilles and provide a scaffolding for gradual healing. The gap created is then closed with a series of sutures.
Now we know that Achilles ruptures can happen for many reasons. One, it can be genetic. Two, it can be on if you're on medication.
Over the next few minutes, I want to review some of the details regarding these potential risk factors, starting with the medications. The broad classes of medications include fluoroquinolone antibiotics, corticosteroids, aromatase inhibitors, and statins. Fluoroquinolone antibiotics include Cipro, Livaquin, and Floxin, among others, and are notably associated with tendon and ligamentous injuries. Corticosteroids can be systemic, taken orally or IV, or injected locally to reduce inflammation. Regardless of the route, they can weaken tendons and ligaments and make them prone to rupture. Aromatase inhibitors like letrozole, anastrozole, and exemestane are used to lower estrogen levels and treat people with estrogen receptor-positive breast cancer and are known to induce tendinopathies. Finally, the ubiquitous statins, some of the brand names listed here, are used to treat high cholesterol levels and are suspect in inducing tendinopathy resulting in rupture. However, some studies suggest that hypercholesterolemia itself may be a risk factor for tendinous injury. And since most of these patients are on some type of cholesterol-lowering medication, the relationship between statin and tendon rupture risks may be correlative but not actually causative. Genetically, sequence variants of the tenascin C or TNC gene and the collagen 5 alpha 1 or COL5A1 gene, both found on the bottom half of chromosome 9, have been associated with increased risks of tendinopathy and rupture. TNC encodes for tenascin C, which regulates tissue response to mechanical load and is upregulated in patients with known tendinopathies, suggesting a contribution to rupture. COL5A1 gene encodes for a component of type 5 collagen, which has an important role in regulating collagen fiber assembly and fiber diameter. So if you have a close relative that has suffered from a number of tendinous or ligamentous injuries in the past, you may also be at risk.
Now I'm going to talk to you guys about my personal experience with Achilles rupture while playing pickleball, right? So it all began on October 16th of 2022. Andrew and I were out at the famous Pictona over here in Holly Hill and enjoying our 5th or 6th game of pickleball. And I reached down to go get a ball that was laying low, and I reached out like this, and I thought, okay, I'm going to get this, and all of a sudden I felt something whack me in the back of the leg, and I thought Andrew threw it.
I did it.
I did. I looked at Andrew and I said, what did you just do? And she's standing there with her paddle in her hand. She goes,
I was not near you at all.
and she still had her paddle in her hand, but that's what it felt like. It felt like someone whacked me right in the back of the leg. So as soon as she said that, I knew I ruptured my Achilles, right? So I first laid on my back and I was able to flex my foot while against gravity. So I knew that some of the tendon was intact, but for sure I felt like I ruptured it because I haven't experienced rupturing this one before. So that was on October 16th, the next day, because I'm a radiologist, I have access to an MRI. I had my MRI done, and this is what my MRI showed. And you can see this is the front of the foot, this is the back of the foot, this is actually where the calcaneus is, and you can see the Achilles attaching to the calcaneus, and right here, about 6 centimeters above that attachment, you can see that it's almost completely ruptured, hanging on by a little thread. So I called my buddy, who's an orthopedic surgeon, got me in 3 days later on October 20th to repair my Achilles. This is that intraoperative picture of my Achilles showing the same thing that the MRI showed, where you can see that there is one thread hanging that tendon together. So based on the criteria we discussed earlier, this would be a Kawada type 2 injury, which would be repaired primarily, which is exactly what happened. So it worked out pretty well. It got it back together. And then I went through my convalescence. And when I first got out, they put me into a boot. And during the surgery, they actually gave me a block. They stuck me up here in the groin. For 3 days, I couldn't feel anything in my foot. It was awesome.
Very important to be on a shower chair and be very careful because you can slip in the shower, you can fall.
That's exactly right. They told me, don't take a shower, don't move, don't do anything, because you can break your leg in half and not even know it. But on the third day, I started to get a little bit of that sensation back, and it started off with that tingling sensation that you get in your toes when you've been sleeping on your foot wrong. And after that, then the pain set in, and then I had to start taking the pain pill. Andrea put me on her PEMF mat, and she goes, you need to try this thing, okay? Just see what happens. And what is PEMF?
Pulsed electromagnetic frequency, and it happens to help vascular flow, this particular device. And so it wasn't just focusing on laying on a mat. There was actually spot treatments that we used to maximize vascular flow to his Achilles.
So I stayed on that thing, did it routinely, like 3 or 4 times a day. And the idea is it generates this little pulsed electromagnetic field, which then, stimulates tissue growth, may improve blood flow. I don't know if it worked or not, but I can tell you my convalescence was pretty impressive. By 3 weeks, I was actually up walking without a boot. And by 6 weeks, I could actually do squat jumps. And I heard that an Achilles repair normally is a 6 to 12 month ordeal, right?
Absolutely.
So I'm a year out. You can hardly see a scar right there. I'd like to think that it's because I'm so young and healthy, but maybe it's also related to the mat, which we are going to talk about on a future show.
Right. So it's not just a mat, it's pieces and parts that actually focus on electromagnetic flow. And what's important to understand is that the low hertz. Our Earth is about 7.86 hertz, and this is at 10 and 30 hertz. So it's very important to understand that field strength is very, very low. Your microwave is at 2.5 gigahertz or 4.6 gigahertz, and your phone is at 5 gigahertz. So this is a very low end spectrum that actually helps of the frequency spectrum that helps the flow.
But don't give too much away. We're going to talk about that in a future date. So the most important takeaway points at this juncture is that A, pickleball is not a sport for old men that is safe to play.
Or ones that haven't prepared their Achilles tendon.
B, if you got relatives who've ruptured a couple of tendons, you may be genetically at risk. So take that into consideration. And C, don't turn your back on your wife if she's out on that pickleball court just in case she's trying to sabotage you.
Well, what about the medications?
And the medications. If you're on any of the medications that Andrea described, of course, that's going to put you at increased risk. Thank you guys for watching.
We're so happy to see you, and we can't wait to see you again and teach you more wonderful things to live a healthy and happy life.
Stay healthy. We'll see you next time.